The American Medical Association, which President Obama addressed on Monday, had a fairly robust debate at its annual meeting about its point of view on public options. Some of its members didn't even want the term in a resolution that would describe how it would approach the bill. Have you gotten any assurances from the AMA that they agree with the concept that you put forward today about a public option that would compete with private insurance?
I don't know what the AMA position is. I want them to look at our draft. I think there's a lot of misinformation about the idea of a public option. Some people think it's going to be a government takeover of healthcare, a single-payer system. That's not what we intend. We want to give people a chance to choose their own insurance plan, just like federal employees get to do, just like members of Congress. We get a list of available insurance policies that we can choose. And one of the choices that will be available to those who go into this exchange or marketplace to look at the choices will be a public plan that will be on a level playing field. It will be a choice, no mandate for anybody to be in it. And it will be for a lot of people who want to make sure that they can rely on it where they feel uncomfortable with the insurance companies and the way they've handled insurance over the years. But I hope when the AMA looks at our proposal and when we hear from them in our hearings, they'll give it a fair evaluation. And we hope they'll be there. If not, we'll agree on what we can agree on.
Go ahead, Mr. Chairman.
Let me just respond to that because I'm anxious to take on those people who are opposing the public option. I cannot think of any doctor that's being told that hundreds of billions of dollars are going to be out there in research and development, that we will be providing nurses and doctors, a real support team. Doctors who are concerned about practicing medicine would be able to say that we, this president and this Congress, have presented them an atmosphere where that's what they can do. For those people who are afraid of competition, they shouldn't be in this business. This is what we're trying to do. Make it an even playing field for all professionals to say they're getting better than a fair shake in what we're doing. So I have talked with a lot of doctors who've said, thank you for giving us an opportunity to do what we decided to do when we went to medical school, and that is to practice medicine.
Mr. Chairman, you're standing up there united about your position on the public option here, but there are a lot of divisions within your own party, most noticeably in the Senate. Are you concerned at all about healthcare reform losing momentum? And given these divisions on the public option, are you open to accepting something as an alternative like a co-op?
We set out in this joint venture among the three committees to try to put language to what President Obama had campaigned on in front of the American people, what he has said since coming to office. And as you saw, he's continued to stress the need for a public option, to defend a public option. We've put, a draft of a public option in this legislation for all of the reasons that Chairman Dingell outlined. Today, health insurance for most American families is just one big surprise. When you go to use it, you find out it's not quite as it's represented, and you spend hours on the phone with exclusions and discussions and referrals to other legal documents that you didn't have at the time that you purchased it. And we just think there ought to be a level playing field, there ought to be honest competition, and the benefits ought to be as they're stated and there when families and businesses need them. And so we think that this is, there are those in our caucus who don't fully agree with the public option. We've had a series of discussions about that. There's been modifications in this draft, but we're at a point now where those discussions should continue in the committees, and so that people can make changes to this draft and prepare it to come to the floor. We understand, we've read all the different positions in the Senate, we've had discussions back and forth, but we continue to believe that this is an important component of real health care reform and an important benefit to American families in that whether they choose the public plan or they choose the private plans in the exchange, they can do whatever they want. This is about choice. They will know that even those private plans will be better because of the public option.
Just to follow up, the president has indicated some flexibility in terms of a co-op.
And that's why this is a discussion draft. That's why this is a discussion draft. The next steps should be taken by the committees after debate and deliberations and hearing from the witnesses.
Congressman,
Could you
can you explain
explain-
why you settled on the 8% number with the employer mandate? The 8%
Henry,
penalty?
you want?
We haven't settled on anything. Everything's on the table. This is nothing locked in cement. And I don't even remember, that's one of the ideas that is there. We talk each and every day. And I just want to report about momentum. I've been here down here a long time, working with 3 committees. The word jurisdiction hasn't even come up. We're working with Medicaid, Medicare, and all of these things. So we got the momentum.
Do you have any figures as far as estimate or guesstimate about how far you could go as far as the price tag? What's the limit as far as the
We're
price tag?
waiting for the numbers to come
And
in.
how do you plan to pay for it?
Well, we're working with the Congressional Budget Office. In fact, every time we think of an alternative, we have to have a different score. Sometimes the Congressional Budget Office tells us one alternative would cost less, and another one would cost more, and as a result of that interplay, we're making our decisions. So we don't have the figures of how much this is going to cost, but we are going to pay for this bill, and we're going to pay for it in 2 ways. We're going to pay for it by cutting down on the expenditures in some of the public programs, Medicare and Medicaid. We're going to pay for it by reforms in the system that will hold down costs for everyone, reforms like choice, and reforms like an emphasis on prevention and primary care. And we're going to pay for it by revenues. We put out in our draft today a list of options for some of the cuts that could be made in existing programs. These are based on a menu of options that the President has submitted to us, and we put them out there, and we'll have them on the table as we consider where to make the cuts. And the revenue parts will be discussed by the Ways and Means Committee, and we'll make sure that at the end of the day, we have a health insurance bill that will cover almost all Americans, will hold down health care costs, will provide affordable, good quality health insurance coverage, and we're going to pay for it.
Can you explain how you got, I believe I heard you think 90% of Americans will have coverage under this plan?
You want to?
Well, we think it's somewhere between 90, somewhere around 95. Again, with CBO, depending on the structure of it, that can change, and so that number's not set in concrete. We know that there's people who are healthy and remain healthy for a very long time and never encounter the system. They just don't show up. There will be for a period of time people who are not aware of this. There's people who today are still trying to get TV with their rabbit ears, after all of the hundreds of millions of dollars of ads and rebates and the rest of that. So again, you want to be careful about what you promise, and we think this is in the ballpark.
How does your proposal address the Dartmouth data that shows like overuse of medical services in Miami versus Minnesota, but not necessarily any better quality?
I think that's what Chairman Waxman was saying with respect to the menu of the President's suggestions on cost cutting and efficiencies in the system and reorganization of the system. I think when you read this legislation, you'll see it's a fairly aggressive list of choices and determinations to be made by the committees. Clearly, we've heard these stories, and they've been documented as they were with the Dartmouth study, of these different outcomes, not necessarily superior health care, but tremendous cost. And that's obviously what we want to attack, because that's to the benefit of families and to businesses and to taxpayers.
In the middle here.
Chairman Waxman, you've been very vocal about pharmaceutical industries paying their share for rebates. I was wondering if you could expand a little bit on the sacrifices you're asking them to make.
Well, we're simply going to ask the pharmaceutical companies to pay us back the money that was a windfall to them as a result of the Medicare drug bill. You know what happened on that bill? There were people on Medicaid, and we got rebates when we paid Medicaid costs for drugs, because the Medicaid law said that the government will get the best price. Well, under the Republican plan, they shifted the people who are on Medicaid and Medicare onto Medicare. So the same people got the same drugs, but we, the taxpayers, paid more money for those drugs. It was a windfall of billions of dollars. we'd like the drug companies to give us that money back and stop doing that kind of thing in the future. That's what we have in our draft.
Stephanie?
Who defines what health care is? I mean, affordable and good quality is great, but who decides?
The physician.
Well, for healthcare services, the physician will be the one in charge. And people can choose their doctor, and the doctor will decide what needs to be done. But we're trying to improve the delivery system. So it's like the Dartmouth study indicated, and other evaluations have shown, that we have a variation from one part of the country to another. In fact, there was an article in the New Yorker that showed that even within Texas, there was a huge disparity of health care costs for similar populations. We want to change that. We want to emphasize more preventive services and primary care services and organized delivery in terms that are called medical homes, providers getting together and figuring out the best care. Too often what we're seeing is that people go to a doctor who's overworked, has to see as many patients as possible, giving them as little time as the doctor may have. And then when there's a complaint, they'll just send them out for another test, which of course the system has to pay for, or send them to a specialist. And what we need are doctors to be able to spend time with their patients and find out what's going on and prevent these problems from getting worse.
Up here in front.
You talk about having a level playing field for the public plan. Does that mean that the public plan is going to pay private rates as opposed to Medicare rates? And if that's the case, then how are you going to save money? How are you going to force savings with that public plan?
Well, the committees are going to decide all of these issues, obviously, but the way we envision a public plan is it will operate the way private insurance plans do. They will have to work within the amount of money they raise from premiums. There will be no government subsidies for them. They'll have to negotiate with the providers of care and see which providers want to give care under that insurance plan, as providers have to decide whether they want to do it under a private insurance plan. In the beginning, I think the public plan will probably use a Medicare as a basis for their reimbursements, but probably higher than Medicare because they want to be sure that they can attract the doctors and other providers to the public plan. But a public plan will be open and transparent, and I think will be looking to be even more nimble than other insurance carriers because they'll try to figure out how to provide care in a comprehensive way, in a preventive way, and hold down some of those costs.
I just like to say, as it relates to the question of rationing and your question, imagine worried in all of this is competition. The whole world, the whole country rather, be watching how these plans intend to work. And you can bet your life with the competition, if one of them get a reputation of not providing that health care or rationing health care, it won't be the United States government that would be directing it. It would be the government prohibiting it, so that what Henry said is true. We've got to take the best of Medicaid, the best of Medicare, kick it up a notch, but at the same time be able to effectively compete. I hope that many of the AMA doctors will be fighting to get involved in the public health option.
Well, if I could just follow up on the last question about the public plan, you will be shocked to hear that the insurance industry has already issued a statement criticizing the public plan in this bill. How could you describe, so it starts out tied to Medicare reimbursement rates and then it somehow transitions off into a more level, how does this work? Is there a trigger? I mean, how do you get from
Well, we're going to have to examine these details in our hearing process, but we want we have some provisions in the draft, but we want these public plans to be able to provide reimbursements as they get started for those who sign up in the public plan. I mean, this is a new plan. Private insurance plans are already in existence. They already have their group of providers. They have their contracts with providers. They often have already negotiated their rates for providers. But the public plan will have to get started, and there'll be a period of time for them to start up. But they will then, at some point, compete, just as every other insurance plan does. Let me comment on the statement that the private insurance companies don't want the public plan. it seems to be what they're saying is they don't want competition. They don't want a plan that can offer services maybe in a more comprehensive way, maybe in a more cost-effective way than they do. After all, you have to recognize the insurance companies have operated on a simple principle that they're not trying to cover those who need the care and then spread the costs. They've been trying to exclude people from coverage for individual insurance plans. They've been trying to see if you're sick and then making sure they don't have to issue an insurance policy to that individual. Well, that will change because we're not going to allow insurance companies to do that. But there are a lot of people who feel that some of those private insurance companies are still going to try to figure out ways to cut their costs by not covering some people. I remember well the story of how there was a plan that said anybody who wants to sign up can sign up. They just have to walk up 4 flights of stairs to get the information. And of course, if you weren't physically able to do that, you never got a chance to sign up in that insurance plan. We want to keep everybody honest. And competition is the best way to accomplish that goal.
No, on the wall. You have the last question.
Mr. Chairman, I wonder if you could talk a little bit about
This is the LA Times.
the Medicaid. Thank you. The Medicaid expansion in the bill. There's obviously a lot of concern among states that the Medicaid right now is not working particularly well. In California alone, many providers are fleeing the program. How do you assure that if you expand this, you're not just bringing more people into a dysfunctional program?
Well, Medicaid is an essential program for Americans below the poverty line, many of whom have very complex problems. They're not the kind of clientele that the private insurance companies are eager to insure at the present time. We're going to keep the Medicaid program in existence. Someday we may talk about them allowing them to go into the exchange, but not for a while. And if we're going to keep the existing Medicaid program, we've got to make improvements in that program. Oftentimes in Medicaid, the beneficiaries can't find doctors, can't find any health provider that will take the rates. And we've got to make sure that they are paid fairly. And we have to adjust the situation with the states. In some cases, we're going to have federal dollars replace the state dollars, and we're going to have to work with the states to make the program one that will be affordable and will be there for those who are entitled to it because of the fact that they are below poverty, and when they get sick, they should have access to the care they need.
I think we got to close out now, even though the chairman of the committees have been explaining the bill to you. We cannot let this moment go by without telling the chairman of the subcommittees that's worked so hard on this, Rob Andrews, Frank Pallone, and on Ways and Means, Pete Stark, who's for decades has been working on it. I want to thank the staffs of the 3 committees. We have relied heavily on them. We would meet. We would decide the direction that we want to go, but they've had the responsibility of working with all of the committees and working together. The leadership has worked with us, as well as the staff of the Congressional Budget Office, which we are still waiting on in order to perfect our discussion paper. We want to thank the House Office of Legislative Counsel under the leadership of Jessica Shapiro and Ed Grossman, and including Mega Renfrew, Larry Johnson, Henry Christop, Wade Ballou, have all helped to work with the President's office to make certain that we didn't accept everything, but everything that he wants is on the table. And this has been a challenge that I can tell you that we as professionals, as politicians, feel very proud of the fact that we've been working so seamless together and that we're coming out with this discussion proposal. Thank you.